Okay. Bismillah, salatu wassalam ala Rasulullah. Allahumma salli wa sallam wa barak ala Rasulullah. Hayakumullah jami'an. Welcome everybody. We are starting our webinar for tonight on a very, very hot topic, which is iron deficiency anemia in heart failure. One of the most promising areas in treating heart failure patients, especially with the upcoming positive data from different trials. And we have with us today three of the most leading and eminent speakers in the field. And without further delay, I would like to present Professor Ayman Hijazi. He will present burden and management objectives. And Professor Ayman is the hematology head section on National Guard King Abdullah Cancer Center in Riyadh, as we all know. Please, Professor Ayman, the screen is yours.
Well, thank you very much. I would like to thank the Saudi Heart Association for inviting me to speak in this prestigious platform. I can see that the number of participants have exceeded 1,600, which is amazing, really. And I'll start sharing my screen with the, I wish it's gonna be clear. So as Professor Kamal has just pointed to, the topic tonight is going to be about iron deficiency anemia related to mainly heart problems, and the agenda, I guess everybody has seen it. There will be three speeches. I will start with mainly the pathophysiology of iron deficiency anemia, and I'll just touch briefly on the management. Dr. Fakhr will go over the management and further details. So before we kick in, I mean, I will start by mentioning how important is iron to the human body and what are the functions that iron is needed for in the human body. Everybody knows that oxygen transport and exchange is the main function of iron in the human body, but in addition to that, there are many other metabolic reactions that iron is needed for, namely electron transfer, heme synthesis, DNA synthesis and repair, ribosome function, and mitochondrial function. So iron is important to the cells, tissues, and the function of the human body. Iron deficiency anemia results in dysfunction in mitochondria, the ranged activity of many enzymes that are needed for energy production in the human body, and this also will lead to abnormal transport and structural proteins and abnormal apoptosis, tissue remodeling in the heart and others, and that leads to impaired organ efficacy. And in iron deficient subject, there will be an impaired exercise capacity, reduced work efficacy, and impaired cognitive function. So the prevalence of anemia, despite of the decrease in prevalence in anemia in the world over the last 2 decades, iron deficiency, which is represented here by the green color, represents the main cause of anemia. And this is a comparison between 1990 and 2010. So despite the improvements in the incidence, but iron deficiency still is one of the most important reasons for anemia. These are the 25 leading risk factors. This is what this was back in 2010. It's unfortunately not very much different now. And iron deficiency ranks number 13 as a cause of death worldwide. This is the prevalence of iron deficiency anemia in the Arab countries in different population and different age groups. As you can see, elderly are represented by the green bars, the blue bars for women with childbearing age, pregnant women in the yellow, adolescents gray, and school children in the orange, preschool children in the purple color. As you can see in Saudi Arabia here, the most common population that suffers of iron deficiency anemia are young ladies, mostly women of childbearing age, representing 40%, and more than 30% in pregnant women. But also elderly represent about 13% of the population that have the iron deficiency anemia. When we look at the hemostasis of iron, the adult individual has around 4 grams of iron content in the body. Of that, about 20 to 25 milligrams are circulated per day due to the destruction of red blood cells in the reticular endothelial system, and then recirculated back to the bone marrow and the liver to be used again. But at the end, the loss amounts for about 1 to 2 milligrams in the steady state, not in the states where the iron is needed more than usual, for example, in pregnant women or women that are breastfeeding. So in a steady state, 1 to 2 milligrams are needed to replace the iron loss that happens on a daily basis. The absorption of iron takes place in the proximal intestine and in the brush borders. I used to get confused with the ferric and ferrous forms, but the ferric forms are with 3 pluses and the ferrous forms with 2 pluses. Ferrous forms are more absorbed than the ferric, so ferric has to be transformed to ferrous, and then the DMT1, which is a transporter protein, that carries the iron into the through the brush borders into the cells in the small intestine, and then excreted in the bloodstream. The rate of absorption is related to many factors, depending on how much iron is in the body, how much is needed, and the presence of inflammation or not. The source of iron in the diet is whether it's from an animal source or from a plant source. There are 2 types of iron that are present, mainly in the animal source. 40% of the iron in the meat, for example, is bound to heme, while 60% represented here by the green dots is non-heme iron. While in the plants, it's all non-heme iron. For a regular human or an adult that takes, 10% of his diet represents heme iron, and 90% of his diet represents plant iron, and the difference is in the percentage of absorption. Heme iron, 25% of the heme iron is absorbed, while only 10% of the plant or the animal non-heme iron is absorbed. And it's also inhibited by many other things. This graph shows how much of the iron is absorbed based on the source of iron. As you can see, the orange bars represent non-heme iron, while the other color, the pink color, represents the heme iron. As you can see, in the veal muscle or in the red meat, more than 20% is absorbed of that iron, while in spinach, for example, where we have the myth of Popeye, and everybody is probably, since childhood, know that spinach is rich in iron, but very small amount, less than 5%, is absorbed of that iron. So if you want to replenish your iron, go for heme iron, and the source is usually animal source. This table summarizes the major protein that involved in the iron hemostasis. One of the most important protein is hepcidin. Hepcidin has been discovered fairly recently, more than 10 years ago, but that is an important regulator of iron hemostasis. It's mainly produced in the liver, and it's increased in the presence of high iron stores. So the main function of hepcidin is to destroy or to inhibit ferroprotein, protein that usually carries iron, therefore inhibits the absorption of iron from the cells in the intestine and mobilization of iron from the cells in the liver and the spleen macrophages. So if you look at this cartoon, at your left-hand side, you have low hepcidin levels where iron is mostly in the extracellular space, and ferroportin is active in transporting iron from the cells to the extracellular compartment, where it can be readily used in synthesizing enzymes and red blood cells. While in conditions where hepcidin is high, and that happens during inflammation, iron is mostly intracellular, and the ferroprotein is degraded, where the iron content in the body is normal, but it cannot be mobilized out of the cells to the extracellular space to be used in its normal function. This is an algorithm actually to help in diagnosing iron deficiency anemia in patients who present with anemia. So in this algorithm, it starts with whether the anemia is regenerative or hyporegenerative. Regenerative means there is high or increased reticulocyte count that is more than 2%. When that is the case, you look second at the MCV, which is the corpuscular volume. And in low MCV, the main diagnosis in this category is iron deficiency anemia, although anemia of chronic disease can be seen in this category, but to a very much less extent. Anemia of chronic disease is usually seen with a normal MCV, and a high MCV, which are big red cells, usually seen in megaloblastic anemia secondary to B12 or folate deficiency. In the other side, where you have reticulocyte count more than 2%, where you have the bone marrow compensating to either bleeding or hemolysis. So the differential diagnosis here is limited. It's mostly either hemolysis, and that can be immune or non-immune, or due to actually blood loss that is continuous with good replenishment of iron and other components needed to produce the red cells. Peripheral blood smear is very important in reaching a diagnosis. What are the causes of iron deficiency anemia? I mean, usually in an individual, it's a combination of more than one factor leading to the deficiency of iron. It's either to decreased oral intake or decreased absorption, increased iron demand, or blood loss. And these are the factors that are related to each category. The most important, probably the most prevalent iron deficiency anemia we see is in young women, where it's a combination of all together. There is a decreased iron intake because of non-healthy dietary habits. Usually the absorption is normal, but there is usually an increased demand because of the menstrual periods and the pregnancy and lactation. And the periods are causing blood loss. So any of these combinations can lead at the end to iron deficiency anemia. Clinical signs and symptoms. Fatigue is actually the most important and most common symptom that we see, although it's not diagnostic, and none of these are diagnostic. But an anemic patient will have pallor, weakness, headache, palpitation, dizziness, the usual symptoms of anemia. But in iron deficiency in particular, there could be a pica where it's an abnormal behavior in eating behavior. We'll go over that in more details. And the symptoms related to iron deficiency can occur despite of the presence of anemia. So there is a state of iron deficiency before patients can develop anemia, where they usually complain of fatigue, irritability, poor concentration, and hair loss. Other features of iron deficiency anemia could be seen here. Pagophagia, craving for ice. Pica, we have mentioned, which is craving for non-food substances such as dirt and clay. Glossitis, which is seen here, inflammation of the tongue, and angular stomatitis can be seen in iron deficiency anemia. Koilonychia is almost a pathognomonic sign of iron deficiency anemia, where you have a spoon-shaped fingernails. Heavy menstrual bleeding represents a leading cause of iron deficiency anemia across the population in all countries, actually. What is the differential diagnosis? If you remember the algorithm, we said MCD is low, and microcytosis are caused by limited number of diseases, the most important being iron deficiency. The second most common is thalassemia, where you have low MCD, but in that case, you have normal RDW, the red cell distribution width, and the RBC count in thalassemia traits is high, despite the anemia. You look, so in low MCD, the first thing I look at is the RBC count and RDW. So if the RBC count is high and RDW is normal, this is likely to be secondary to a thalassemia trait, which is not uncommon in our population. So if these are not high, I mean, the RBC is not high and RDW is high, then the likely diagnosis is iron deficiency. These are the different states of iron deficiency, as I mentioned earlier. I mean, before, in a normal subject, you will see the parameters here. Iron depletion, the first thing that goes off is the iron stores, mostly in the bone marrow and the liver, and ferritin level goes down to 20 or even less. After that, we have a state of iron-restricted erythropoiesis, where you don't have anemia, but you have a low ferritin level around 10, absent iron stores, and low transferrin saturation. In the frank iron deficiency anemia, you have all of these components in addition to microcytic hypochromic anemia. What tests do we do to diagnose iron deficiency anemia? The first thing we look at after the hemoglobin is red cell indices, MCV, MCH, in addition to the reticulocyte count. Serum ferritin level is a very important test that can help in diagnosing patients with iron deficiency anemia. Now, the problem with serum ferritin, we'll go over the serum ferritin in further details, but the problem, it's an acute phase reactant that could be high secondary to an inflammatory process, and when it's high due to that, iron deficiency anemia can still be present with a high ferritin. Serum iron and TIBC are not very much reliable, but when you divide serum iron by TIBC, you get transferrin saturation, which is a more reliable index of iron deficiency. Peripheral blood smear, we'll look at certain peripheral blood smears, that what is seen in iron deficiency anemia. Now, soluble transferrin receptor is very much specific and sensitive, but it's not available in most of the labs. We don't do usually bone marrow aspartate biopsy to diagnose iron deficiency, but if it is done for another reason, definitely we can look at the iron stores. Now, serum ferritin, as I mentioned, is an acute phase reactant, and this is the main drawback of this test. What is the best cutoff level of serum ferritin? If we use 15 as the cutoff level, this test has a 98% specificity and 75% sensitivity. If you choose a higher cutoff level, which is, for example, 30, then the sensitivity goes up, but the specificity goes down to 85%. So it depends on what level do you take, but 30 is a reasonable number that we look at. Less than 30, likely this patient is suffering from iron deficiency anemia. So what is a differential diagnosis of low serum ferritin? Iron deficiency and nothing else but iron deficiency. So a low serum ferritin does not have any other differential diagnosis. As I mentioned, in the serum iron total binding capacity, these are not very much reliable, but transferrin saturation is helpful. Soluble transferrin receptor level is proportional to the level of expression of the transferrin receptor on the cells. It's not an acute phase reactant. It's an expensive test. It's not available in most of the labs, but it's a very specific test. Now, these are peripheral blood smears from a patient with iron deficiency anemia. As you can see, the red blood cells are pale, mostly in the center, and this pallor is more than the normal, in addition to the presence of pencil-shaped RBCs that is seen in iron deficiency anemia. These are bone marrow slides, and this is Prussian blue stain, which stains iron. Normally, a bone marrow stains for Prussian blue, that represents the iron stores. In iron deficiency, as you can see here, it's depleted and there is no stain. I'll touch on the management of iron deficiency, and I'll leave the details to Dr. Fakhr to go over it. So mainly to replenish iron, I mean, you have three sources, three types of management: dietary advice, oral iron, and parenteral iron. And this summarizes the whole or blood transfusion. So oral iron, the best oral iron, I mean, we have different formulations of oral iron, ferrous sulfate, ferrous gluconate. There are other combinations with folic acid. In fact, ferrous sulfate is the best oral iron. It carries the highest elemental iron, but the problem with that, it's the hardest on the stomach, and it causes a lot of GI symptoms. These are the factors that affect iron absorption, either inhibit or enhance, and they are very important, as oral iron is usually taken on an empty stomach, not to interact with food that decreases usually the absorption. Any calcium-rich foods, milk, for example, tea and coffee that is rich in tannin, and phytates and cereal, these are they all decrease the absorption of iron, while heme iron is best absorbed, and the presence of vitamin C or ascorbic acid improves the absorption of iron. So if you start a patient on an oral iron therapy, if the patient is really taking the medication, you expect to see a peak of reticulocyte count in 7 to 10 days and increase in the hemoglobin in 2 to 3 weeks. Normalization of hemoglobin should happen within 2 to 3 months. And then you have to keep on giving at least for 6 months to replenish the iron stores. Now, what are the causes of failure of response to oral iron? These are many, but the most important factor that we see among all age groups and among all patient categories is failure to take the tablets, non-compliance. And that is mostly because of the GI adverse events that patients suffer from when they take oral iron, can affect more than 50%. And usually, I mean, the most important population that really complain or have iron deficiency anemia are young females. And young females, sorry, Dr. Fakhr, but are not really compliant with the pills that are prescribed by the physicians. IV iron, there are different formulations. We'll go over the formulations, and there is a stigma that has been stuck to the IV iron, which is anaphylaxis, and that is based on the high molecular weight dextran that has been used in the past. And in my lifetime, I have not seen a single patient who developed anaphylaxis secondary to iron. I mean, this could be misinterpreted. The reactions that patients develop could be misinterpreted to anaphylaxis, but many of these reactions are mild, that could be taken care of by just stopping the infusion, starting, or giving hydrocortisone and diphenhydramine. Now, how to calculate the iron, the total iron you need to give to a patient? The most helpful equation is the Ganzoni, where you, and this is the one, I mean, you really subtract the target from the actual hemoglobin, multiply it by body weight times 0.24, and you add 500 milligram for the stores. So parenteral iron has been used for more than 60 years, and the high molecular weight iron dextran had where the anaphylaxis was mostly related to is not being used anymore. In 1998, iron sucrose has been introduced, and many physicians started using iron sucrose. Until now, is being used widely. Now, the problem probably of iron sucrose is the amount you can give. No molecular weight dextran, Cosmofer has been in 2001, ferric carboxymaltose 2008, and iron isomaltoside in 2010, and lately ferromoxitol. It's now the indication, I mean, when we were in the medical school, I mean, we were taught that do not use IV iron until you try oral iron. This notion is not true anymore. I tend to give IV iron more leniently because I know many of the patients that I prescribe oral iron to are not going to take their iron. I mean, very small number of patients take their oral iron religiously, and they have a good response to that. I try most of the time oral iron, but I mean, upon the next visit, if this fails, I immediately change to IV iron. Blood transfusion, I recommend against using blood transfusion in most of the patients where the cause is iron deficiency, especially in young people, but blood transfusion could be given in very low levels of hemoglobin, even less than 7 grams per deciliter, or in patients who are really symptomatic and have comorbidities, maybe in patients whom you need to give them the blood in conditions where the heart cannot cope with the degree of anemia that is present. Why we are not happy with giving transfusion? The side effects of blood transfusion are many. There is definitely, although small, a risk of death, major morbidity. There are many reactions and side effects related to volume overload, TRALI, GVHD, and there is also the risk of transforming viral infections. This table summarizes the different forms of IV iron. I will not go over the details. I'll leave that to Dr. Fakhr. I'll just end by showing a small study that we did in our institution, comparing two different forms of IV iron, which is ferric carboxymaltose and ferrous sucrose. So in that, we looked at 800 women complaining of uterine bleeding, and we calculated the cost comparing two scenarios, where in the first scenario, I need to move this. In the first scenario, iron sucrose is given, and in the second scenario, ferric carboxymaltose. There was a saving in the cost of the ferrous. The sucrose was more than $1 million, while in the ferric carboxymaltose was 725,000. So more than $250,000 was saved. Now, if you look at the second chart here, if you look at the direct cost of the IV iron here, I mean, the ferric carboxymaltose is 2.5 times the cost of iron sucrose. But the indirect cost, including the nurse wage, the doctor, the disposables, the overhead costs, in addition, which we did not calculate, is the time needed to give the amount of iron in a busy infusion suite, where you need to give 4 to 5 infusions of iron sucrose to reach the total amount needed, while 1 infusion of ferric carboxymaltose is needed in most of the time in the same setting. So in conclusion, iron deficiency anemia is prevalent. Ferritin, in the absence of inflammation, is an excellent indicator of iron state. Oral iron is, could be effective, but poorly tolerated. The available IV iron products are much less allergenic than the old high molecular weight dextran, and should be used, without major caution. With this, I conclude my talk, and thank you for listening.
Thank you. Thank you very much, Professor Ayman. Quite a comprehensive overview for our iron problems and the different possibilities and alternatives that we have in the market right now. So we'll keep the questions till the end, and we will move now to our next eminent speaker, Professor Faiz Al-Shair, to speak about iron deficiency anemia, specifically in heart failure. Professor Al-Shair is Professor of Cardiology, consultant of Cardiology at King Khalid Hospital at King Saud University. So please, Dr. Faiz, the screen is yours.
السلام عليكم ورحمة الله. أبارك لكم بالعشرة الأواخر من رمضان إن شاء الله بالتوفيق بإذن الله. I would like to thank the Saudi Heart Association for inviting me to that very important event, iron deficiency anemia in heart failure. If we look here, that iron deficiency, when you have an iron deficiency, there will be a decreased production of hemoglobin, and this will lead to decreased oxygen delivery and decreased oxygen consumption. Also, iron deficiency will lead to reduction of the aerobic enzymes and decreased production of ATP and decreased oxygen utilization, and so at the end, the oxygen consumption will be less. So iron deficiency will lead to defective oxygen delivery and utilization. If we come here to look at the heart, usually the heart beat about 70 beats per minute, and the heart muscle is containing smooth muscle cells, fibroblast, and cardiac myocyte. And this cardiac myocyte, actin, myosin, thrombomycin, and intercalated disc need ATP for its functioning. So we usually produce and consume roughly our body weight of ATP every single day, and heart produce about 95% of ATP in the mitochondria. So if there is a reduction, a deficiency, iron deficiency, this mitochondria will not act properly, and the ATP will be impaired. So if we have an abnormal mitochondrial production, what will happen to the heart? There will be a progressive worsening of heart failure status and deterioration of the systolic function and contractility with impairment of the left ventricular diastolic function. Also, there will be a fatigue of the muscle, exercise intolerance, weakness, and fatigue and insulin resistance. And over the kidney, the renal dysfunction and poor control of the blood pressure. Nearly 1/3 of the cardiac myocyte iron is stored inside the mitochondria, and the heart using more iron than the other organs, about 50 to 150% stored in the heart. Mitochondrial dysregulation has been linked to different heart conditions and heart disease. If we look at the mitochondria, we have the mitochondria, there is a lot of complexes, and to go for Krebs cycle in order to produce an ATP. So here we have 3 complexes, use 2 different sources of iron. Iron-free sulfur clusters going to the mitochondria, or the heme iron complex 4, and this at the end will lead to production of the ATP. And so iron deficiency might lead to worsening of myocardial dysfunction and no more ATP. If we have a reduction of ferritin, for 84% reduction in ferritin level, will lead to myocardial dysfunction and systolic dysfunction, and this is the reason for heart failure. So if we come here to that very important figure, you see here the contractility in the gray color. There is a contraction and relaxation, and if there is in the blue one, if there is a iron deficiency, there will be contraction, but then impaired relaxation. And after 4 days of iron depletion, we have an impairment in systolic and diastolic dysfunction. So the mitochondrial deficiency will reduce the contractility and the relaxation, and will lead to the myocardial dysfunction. This is a trial. Myocardial iron content is reduced in advanced heart failure. The donor heart, if the patient had, those who had heart failure, they have 22% reduction in their iron compared to those without heart failure. So decreased deficiency of iron content in the myocardium itself. Now we have a problem of cardio-renal erythrocyte axis. The kidneys secrete erythropoietin to form in the bone marrow to form the RBCs, and this hemoglobin will go to the blood, and the blood will circulate. So what are the causes of iron deficiency anemia leading to heart failure? We know that anemia of chronic disease is the most important one, and iron deficiency represent about 20% of anemia of chronic disease. And we know that chronic diseases are usually due to inflammation and inflammatory diseases like heart failure. Cytokines, there will be increased cytokines, interleukin-6, tumor necrosis factor. There will be an impairment in the erythropoietin production and apoptosis of erythropoietin, and also hepcidin release. If we come here to the absolute iron deficiency, why we have absolute iron deficiency, as mentioned by Dr. Ayman, malnutrition due to anorexia, malabsorption due to GIT edema, or using of proton pump inhibitor on phosphate binder or hepcidin, or GIT losses due to antiplatelet, anticoagulant, or mucosal integrity. Also other causes like hemodilution, salt and water retention, volume overload, this can cause anemia. AC inhibitor and ARB itself will inhibit the bone marrow and also inhibit the production of the erythropoietin. If we come to the renal impairment and decrease in GFR, this will it is an inflammatory, will increase cytokines and hepcidin, and this all affecting the erythropoietin release. Let us to come here. So now we have no iron to the myocardium, and the mitochondria is depleted of iron. So what will happen here? The decreased cardiac output, and when you have a decreased cardiac output, there will be a decreased renal perfusion, and this decreased renal perfusion will lead to activation of RAS system and volume overload and hemodilution, and result into anemia. Also, renal perfusion, decreased renal perfusion will lead to chronic kidney disease, and this chronic kidney disease will reduce the erythropoietin release and decrease the bone marrow function, decrease the hemoglobin, and this will lead to anemia. Also, decreased renal perfusion will lead to a pro-inflammatory cytokines increase, and this will inhibit erythropoietin, and S inhibitor also will, and ARB will inhibit the erythropoietin. So we have a lot of mechanisms to form heart failure. This is apart from anemia of heart failure, high cardiac output failure due to anemia and other causes of anemia. Here, very important, if we have chronic illnesses like congestive heart failure, chronic kidney disease, or anemia, if you don't have any of these, the mortality rate, two-year mortality rate in 5% sample of Medicare in USA is about 7% compared to those who had the three together. I think the image is not clear. It is about 45% if you have this the combination of the three, and varying if you have one or combination of the other two. So the presence of multiple chronic illnesses will increase the mortality rate. Here, a very important slide is showing the comorbidities and cumulative percentage over time of the comorbidities. We have here an evidence of about 20 comorbidities. One of them is anemia, and anemia represent about 26% in patients with heart failure. If you look at different studies and different trials, the prevalence of heart failure, of anemia and heart failure varies from 10% up to 70%. Why that? Because of the definition of the anemia. There was no universal definition of anemia before, and for example, VALHAF trial, the hemoglobin less than 11. For elite 2 trial, the hemoglobin less than 12.4. And for example, here the Macallan trial, hematocrit value less than 40. So we have different definition of anemia. Now the universal definition of anemia is hemoglobin less than 13 in male and less than 12 in female. So 50% of those patients with heart failure, they have anemia, iron deficiency anemia, and usually common in inpatient compared to the outpatients. Usually inpatient 30% compared to 20% on outpatient. Here, if we have heart failure and you have any of the comorbid condition and super added to it an anemia, so there is a huge economic burden and huge cost, and charges are very high if you have anemia added to the other comorbidities. Very important slide here. The more severe the heart failure, the more the prevalence of iron deficiency anemia. They here reaching to up to 80% on those who had NIHA class 4 compared to NIHA class 1, about 10%. This is a study which studied about 500 patients with chronic heart failure, and the definition of the iron deficiency anemia, ferritin less than 100, or ferritin for less than 300, transferrin less than 20%. And what the prevalence of anemia was in this group was about 37%, and it is higher in women compared to men, and also was more higher in those who had the New York Heart Association classification 4 compared to 1 and 2, and also in those who had NT-proBNP higher level and C-reactive protein. So the inflammatory markers higher, the NT-proBNP higher, and the NIHA class. So all this is associated with higher prevalence of iron deficiency. Here, very importantly, the relation between hemoglobin and the mortality. In this study, the lowest lowest mortality at hemoglobin of about 14, and the lower the hemoglobin, the higher the mortality, and also the higher the hemoglobin, the higher the mortality. It looks like we have here some sort of U-shaped curve, because we know increased hemoglobin was hyper viscosity and a lot of complications. So definition of iron deficiency in normal individual, the serum ferritin less than 30 microgram per liter in male and less than 20 in females. And this is this iron deficiency because this level, because the normal person can compensate, can increase absorption, bone marrow can be active. But while in heart failure, because of inflammatory status, and ferritin is an acute inflammatory reactant, should be raised. So the serum ferritin here less than 100 microgram per liter. This is called absolute iron deficiency, or a relative iron deficiency if the serum ferritin less than 300 and transferrin saturation less than 20%. So what is the effect of this iron deficiency? Iron deficiency will lead to impairment of the health-related quality of life, will impair the exercise capacity, and will lead to increased hospitalization and increased mortality. I will discuss each one of them separately. So iron deficiency appears to have a greater predictive value than anemia. This is independent of the anemia and hemoglobin level. Okay, so the quality of life. Quality of life, we have multiple methods to measure the quality of life. We have Minnesota Life Heart Failure Questionnaire, Kansas City Cardiomyopathy Questionnaire, NIA class, 6-minute walk test, and we have multiple domain: physical, psychological, social, emotional, sexual, and mental, and all this will be affected by the iron deficiency anemia. The study shows here that those who had anemia and iron deficiency anemia, they had worse quality of life compared to those who don't have without anemia or iron deficiency. And those who had iron deficiency, it has a double risk compared to those who had anemia alone. Here we show here that iron deficiency worsens the quality of life, and the anemia, there is not that significant difference in the quality of life itself. So iron deficiency reflects more on quality of life. Then exercise impairs systolic and diastolic function of the heart, the dyspnea, fatigue, and we can assist exercise by peak oxygen uptake and ventilatory threshold and 6-minute walk test. And this trial here showed that those who had anemia and iron deficiencies, the peak oxygen consumption, peak VO2 is less compared to those who had without no anemia and iron deficiency anemia, and also those who had iron deficiency anemia, they are more worse compared to those with anemia alone. This hospitalization, we come to hospitalization, increase 30 days re-hospitalization and readmission, and this will lead to a huge economic burden on healthcare and in society. This is the hospitalization also here. Patients who had anemia and iron deficiencies, they are more prone to be readmitted compared to those without anemia and iron deficiency. Here, the mortality. We come to the mortality. The mortality here is higher in those who had iron deficiency anemia, iron deficiency and anemia, compared to the nothing at all. And the iron deficiency alone is getting double risk compared to anemia alone in heart failure patients all. Here we have two trials. We have this trial, 8-year survival rate in congestive heart failure patients. Those who had iron deficiency, they have worse survival compared to those iron sufficient. And also in this trial, 3-year survival also confirmed that those with iron deficiency had worse survival compared to the no iron deficiency. So what is the recommendation of this of the guidelines? They consider iron deficiency in the diagnostic workup for all patients with newly diagnosed heart failure class 1 evidence 1C, and evaluate patients symptomatic symptomatic patient with heart failure. And also you can do iron assessment 1 or 2 twice yearly, and with each hospitalization. So what is the algorithm of work? If you have patient with the reduced ejection fraction, just check the iron. If the criteria of the iron, the diagnosis of iron, just confirm, okay, just go for the hemoglobin. If the hemoglobin you check, you find anemia, go check why this patient had anemia and go for the whole algorithm for diagnosis of anemia. And if no, just give iron supply, usually IV, but don't give IV if the hemoglobin is more than 15 grams. What is the guideline saying here? Intravenous ferric carboxymaltose intravenous should be considered in symptomatic patients with HFrEF and iron deficiency. By definition, serum ferritin less than 100, or ferritin from 100 to 290 with transferrin saturation less than 20, to alleviate heart failure symptom and to improve exercise capacity and quality of life. And this from where this comes from the trials that improve the quality of life and NT-proBNP over 6 months, FAIR HF and confirm HF trial, and these trials I will discuss it now. The American guideline here, this is European guideline 2016. The American guideline initially in 2013 doesn't believe in that, but in 2017, iron, IV iron might be reservable in patients with NIA class 2 to 3 and class 2B. A Scotch guideline also, but they go with the criteria of the trial and also confirm that you can give an iron IV. Let us to go for the trials. Here, the FAIR HF trial. This is the main inclusion criteria: patients who had heart failure, class 2 or 3, ejection fraction less than 40, or class 3 if ejection fraction less than 45. Hemoglobin from 9 to 13.5, and a definition of the iron deficiency anemia. There is a protocol to interrupt. If the hemoglobin goes more than 16 and ferritin level reach to 800, you stop and restart again if it drops. What is it is double blind. It's using of ferritin and plaque just to make the difference from placebo, and what to give a correction phase and continue for 6 months. Okay, so after that they assess the New York Heart Association classification and the patient global self-assessment. Here, patient global self-assessment, it is improved consistently after 1 month, after 3 months, and after 6 months, and it is persistently high, and 50% of the patients remain in better situation, much and moderate better situation. In New York Heart Association classification, also persistently improved after 1 month, after 3 months, and after 6 months, and 47% remain in NIHA 1 and 2. And 6-minute walk test, there is an improvement of about 33 meters. Patient can walk more. And in Kansas City cardiomyopathy questionnaire, it is also here significantly improved quality of life. And in European quality of life 5-dimension score, this is another type of score. It is persistently elevated, improved. They go here and they want to check the safety endpoint. There is no difference in death, no difference in worsening heart failure, no worsening, no in first hospitalization for any cardiovascular reason, or hospitalization or death for other reasons. So it is very safe and has no any drawbacks. The other trial, they make the confirm HF trial. It is the same study, multi-center, randomized, double-blind, placebo-control, almost the same inclusion criteria. They go for correction phase. They give higher dose this time in correction phase, 1 gram for 2 weeks. And then they go for the assessment of 6-minute walk test after 6 months, and the safety up to 1 year. And they look for the secondary endpoint like iron deficiency biomarker, NIHA class, or the other quality of life. What they found here, they found that there is a persistent, also there is an improvement in 6-minute walk test over time up to 1 year. And this is good. And the fatigue score, patient feels less fatigued compared to the placebo, and they are doing well. So also questionnaires like assessment of quality of life, all through the study period, there is all continuous improvement in the quality of life, and also in the other quality of life 5D scores. So they did some analysis, and they found that hospitalization due to worsening heart failure is improved or much better compared to, and the other is not affected. So that's why they will do another studies to assess the mortality and hospitalization. Another trial, this is Effect HF trial, 200 patients. They give the same ferric carboxymaltose and the standard of care, and they check the peak VO2 compared to standard of care, and it was found that this iron replacement improved little bit the peak VO2 because the placebo they're getting worse. So there is a meta-analysis. They collect all the 3 trials, the FAIR and the CONFIRM and the EFFECT trial, and to look for the mortality. And it was found that heart failure hospitalization was much less due to iron, and also the cardiovascular mortality is reduced. And when they did the other trial with iron sucrose, so another 2 studies, 5 meta-analysis, they found also persistently that there is a reduction in the mortality and hospitalization, and that's why they are encouraged to do these trials. Now there is ongoing 4 trials. It started on 2017 and maybe they're supposed to be released this year. In acute, to measure the acute heart, assess the acute heart failure patients, and also in chronic heart failure, and also in patients with HFpEF, in order to detect this. So we are waiting for these results, and also the iron, as mentioned before, oral iron is no benefit for Ironman studies. So in conclusion, and I want to summarize my talk. Iron deficiency, this is the definition: serum ferritin less than 100 mic per liter, relative serum ferritin from 100 to 300, and transferrin less than 20%. What is the effect? It will affect the mitochondrial dysfunction and cause oxidative stress and cellular apoptosis, reduce myocardial dysfunction, and will lead to impairment of systolic and diastolic function. And this will, at the end, will reduce the quality of life, will decrease the exercise capacity, and will impair the increase hospitalization and increase the mortality. And thank you.
Well, as usual, Dr. Faiz, mashallah, quite comprehensive, yet light presentation. Thank you very much. And let's shift now to Dr. Fakhr Al-Yubi. She will present the current management and paradigms for iron deficiency anemia and heart failure. We all know Dr. Fakhr. She's the president of the Cardio Clinical Pharmacy Group in Saudi Heart Association. And this group actually is one of the most active groups under the umbrella of the Saudi Heart. And this activity that we're witnessing today is part of their routine achievements. So without further delay, Dr. Fakhr, the screen is yours. Dr. Fakhr, we cannot hear you. Can you please unmute yourself?
Can you hear me now? Hello? Yes. Assalamu alaikum rahmatullah. Good evening, everybody. Thank you, Dr. Kamal, Dr. Ayman, Dr. Faiz. It's a wonderful webinar. Iron deficiency anemia is a problem, and you made my life easy by explaining about this problem, and of course how to diagnose it, how to come over this problem, and of course why are we here? Because as everybody was seeing now, that iron deficiency anemia is a problem. It's not just one specialty problem. It is all over the specialties in medicine. Everybody should participate. And why do I actually talk here in this webinar? Because as you can see, there's a lot of dosage forms, a lot of salt, a lot of combination of molecules that we really need to touch base on. I will not be able to cover everything, but at least I will try my best to go over. I was just actually listening to Dr. Ayman telling us that among young adults in Saudi Arabia, the iron deficiency anemia was reported. We did a study last year, and it was confirmed. The point here that was new in our study is that we thought that the awareness, the public awareness, was a problem for those who are underage, who are teenage. But we did our study on the college, and you can see that this age reported that they are suffering from iron deficiency anemia, which means that the awareness is not just related to teenage and ordinary public. Even the high school and the college girls were reported to have iron deficiency anemia, which means that we have to work very hard on the awareness part, because we found that the dietary lifestyle was a problem, and also the other thing is using some medications like non-steroidal and other, of course, medications might cause this problem. So we can really have a very important awareness campaign for that, because we are not alone. Everybody around the world are reporting this problem, but we can tackle it by focusing on the awareness part for the group of age, and of course by treating the chronic illnesses that is causing it. And this can be, first of all, done by a proper dietary intake for the public. The other thing is, of course, stopping the bleeding sites, which is another concern that we will cover in another webinars. I know that we all blame pharmacists sometimes about medication error, but again, some medications, if you like it or not, they have the side effects of causing anemia. And we should not just wait. We should do something for that. And that's why we have to follow our patients. We cannot give a patient an appointment every 9 months or 1 year telling them that, okay, you're good, you're fine, we'll see you after 1 year. We really need to follow the patient. We really need to follow the lab work of the patients. We have to follow the ferritin for heart failure patients. And you have to see the levels that they are recording. As you can see, the numbers are very important now. I'm sure Dr. Ayman and Dr. Faiz had a very good, inshallah, touch base on the numbers, because a lot of practitioners are asking us, where should I say that this is a deficiency? Now, there you are. The numbers are there. You can see either this alone, the ferritin, or ferritin on the top of. So the point here is that first we need to diagnose. The second one is, what medication should I write for my patient? I do really face a lot of patients with this polypharmacy problem in the clinic. Believe it or not, most of them, if they want to skip anything, they will skip the ferrous fumarate or the ferrous product just because they say, that's okay, I don't need it. I have other drugs to take. So now let us cover about the difference between oral and injectable iron. Oral have been there since a long time ago. They are a very good supplement for the iron deficiency anemia. They have a major problem, which is the adherence of patients to this medication. You tell the patients to take a tablet every day, or sometimes even take it twice daily. Honestly, I'm sure that 50% of you face that patients do not take it regularly like that. While in the IV products, the good thing about it is that you need to admit the patient, you need to calculate the proper dose, but trust me, you will really achieve the goal in a very short time. Why? Because the patient is coming for this iron, they will be hospitalized for it. You make sure that they take the proper dose and you follow the patient. So what about the oral iron salts? You can see sulfate, fumarate, gluconate. We hear a lot about them. I face a lot of questions telling me what's the difference between these kind of products or formulation. Some of them, they have on the top of them, they put ascorbic acid to improve their absorption. The other thing is that they might put it in the syrup form, capsule, and so on. But the difference between all these products are the elemental iron. You can see now the most one that has the most elemental is the ferrous fumarate. But the more elemental iron they have, the more side effects they will produce. The other important thing about the oral product is what we call the dissolution time. You have a tablet, it goes into the stomach. We need to know what time does it need to release the iron into the stomach, then be absorbed and go to the system. You can see the shorter time is for the sulfate. So fumarate has the highest elemental iron. Sulfate is the least dissolute. And the quicker one to be absorbed is the fumarate. Comes after that is the sulfate, and so on. So whatever type of iron supplement you are giving, you're not even increasing the absorption of iron more than not even 40%, 40 plus. That's the hugest amount that the oral supplement can give. So sulfate is a good one. Fumarate is another good one. But again, whatever the patient will absorb will not have more than 30% of the tablet to be absorbed. If you are looking for a quick recovery of a less progressing problems for your patients, I'm sure this will not be your proper solution. Let us focus on the injectable ones. Now we have different types of injectable iron. The new one is the carboxymaltose. The one that we have good experience in is the dextran and the saccharose. The molecule is bigger with the carboxymaltose. It is a high stable product, and it works in a pH of 5 to 7. Now, the good thing about it is the half-life is from 7 to 12 hours. What do I mean by that? I mean by that it will stay longer in the body because the elimination half-life will be even longer. This is important in the kinetic. What about the others? Saccharose, even dextran. Now, again, the longer it stays, but the more complications it produces. So now you have to evaluate which one should I go with. What do I mean by this? If I'm talking about carboxymaltose, the dose is 50 milligram per kg per body weight. If I have, of course, a normal body weight, it's given in 15 minutes. It's given once every week. We have to, before giving the next dose, do the level of ferritin and iron in the patients before we introduce the other dose. While in dextran, again, it takes about 4 to 6 hours, and it has to be given 2 to 3 times a week, and sometimes even go to 5 times a week, like what we do in saccharose even sometimes. So the more you are exposing the patients to hospitals, the more there is infection acquired from the hospitals, the more costly to the patients, and the less adherence of the patients to your medication. Another problem that we were facing in the old products, dextran, is anaphylactic problem. Again, I know that anaphylactic shock is not common, but we face a lot of patients who really have an allergic reactions to this molecule. That's why we always have to observe the patients. Imagine you have to see the patients about 10 times. Sometimes we reduce it to 5 times, which is a high number again, while you can just give it in 15 minutes and patients will go back home. What about the iron deficiency itself? It is a problem in heart failure. It really worsens the progression of the disease. It has to be treated as soon as possible by using injectable iron. And of course, we have to follow the patients to screen about their tolerability and their outcome of such replacement. The oral intake and the iron intake, again, of injectable medications. In case of heart failure, if I have a chronic heart failure with a proper hemoglobin level, oral is your choice. But if I can really reach my target within very few weeks, I think in this case we will take the injectable ones, and you can follow in this case the European Society of Cardiology that tells us if you have a HFrEF patients who have a ferritin of less than 100 or 100 to 300 with a transferrin less than 20, you have to, first of all, you have to know what's the cause of the problem. You treat the patients. You treat the patients according to their gender, male or female. Why I'm saying that? Because according to their gender, we're going to calculate the dose. There you are. Now, I need you to concentrate with me. If we have a hemoglobin that is less than 13 in male and 12 in females, this is where we introduce the injectable. Otherwise, if it's normal or more than 15, you don't use IV at all. As you could see, Dr. Ayman was telling us about the formulation. Now, this one actually, it's a very easy formulation. It can be given in the clinic. This is what we do in the clinic as a pharmacist. We go and we take the numbers, we calculate it, but to make your life a little bit easier, I want you to follow this one. Now, we have a table here that tells us about the hemoglobin levels. Now, this is very helpful. You combine the hemoglobin level with the patient weight. If your patient's underweight and his hemoglobin is less than 10, so you go with 500 once daily. Again, it's very easy. You can put it in the clinic. You can use it because you will apply this on the patient with a follow-up again with the new level of iron that you're going to take on the next visit. You have to follow this table so it will not reach toxicity. Usually what happens, we give the dose, we tell the patients to come after 3 months in order to see which place is my patient in, or is my patient is within the 15 now, so it's an oral supplements and that's it. That also ferritin should be monitored in patients at once or twice per year. So now we know how to calculate the dose. We can see all the clinical trials that was done on heart failure patients telling us that you have to be quick, you have to replace the iron. This will decrease the complications of the patients who have HFrEF. The guidelines telling us it's a 2A. They told us to give injectable carboxymaltose in this case. And again, the dose is, as I explained to you the last few slides. Until now, there's no enough data for the HFrEF, so still we have to wait for that. And the other thing, we have to measure the safety and efficacy of this product on the patient. And the other thing is that we have to make sure that we are giving the proper dose. We are giving it in a chronic conditions to improve the outcome. The other thing is make sure that patients are not sensitive or hypersensitive and so on. What about the cost of this medication? Now we know that pharmacoeconomic is a very important burden, and it's actually affecting the management of iron deficiency anemia. What do I mean by that? A lot of patients, we really diagnose them and they really need an iron supplement. They sit with us at least one visit, and that's it. They don't come back again for the other 3 or 4 visits. So we didn't actually treat the patient. To do that, I went over a study that was Dr. Ayman, the primary investigator, and he was telling us now his results. And you can see that the cost was lesser in the once carboxymaltose preparation compared to the ones that are given several times. So saving money is also important for the hospital and for the community. And that's why I do really focus on the role of pharmacists. First, they have to identify the proper patients for treatment. They also have to be part of the screening issue. They have to be part also of the drugs that are causing this anemia. They have to be part of the formulation. Is it an oral or an injectable one that we're going to use? Either or, you have to consult them at least to know the proper dosing for your patient. And the other thing, the adherence to the medication. What's the purpose of giving ferrous fumarate, for example, for a patient who will not take it? So I'm just wasting the patient's time, the clinic time. I'm wasting even the outcome that could be actually improved within the coming few months. And instead of doing that, you can at least support giving another form or formulation and make sure that the patient is following your instructions. The other thing is that always their clinical practice is very important lesson. Don't give and run away. You have to give the patient the medication and follow them. This is exactly what we do in the clinic. In the heart failure unit, there is a very important way or methods or tools to improve the patient's adherence to their medications. Why? Because most of our patients do not adhere to their medication. Some of them is because of cognitive problems. They tell you, I forget. So please try to give any kind of instructions like a dispenser reminder, an application on their mobiles, putting the medication inside, making sure your patient's education is really coming out with the good results. Make sure your patient is really understanding what you're talking about. Now, we all know that it's an important thing to have an awareness to the proper dietary lifestyle for the Saudi population, and of course for the proper avoidance of some medications that could be an OTC medication, but they are causing anemia to our population. The other thing is that in HIF patients, we still need more data to work it up. If we can do this within the coming few years, it will be an excellent result. Iron deficiency anemia is a place for treatment in heart failure patients. According to the guideline, it could be managed by injectable molecules. Cost-effective is the module that we are running in, and this is actually the new era of therapeutic treatments in Saudi Arabia, where actually, again, it's not the cost of the drug, it's the overall cost of the medication with the admission and the outcome of the patients. Thank you very much.
Thank you very much, Dr. Fakhr. All right, so thank you for all our eminent speakers. And may I say that we are just at 3,000 participants right now, and the amount of questions is like a flood. So I think if we answer all the questions, we need another 232 months to answer. So if you excuse me, I will have to skip some questions, of course, for the sake of time. But I randomly choose some questions, and I will leave the floor open. So any of our eminent speakers would feel comfortable to answer the question, please go ahead. The first question is that is there a data on men rather than female about iron deficiency anemia and ischemic heart disease in terms of relationship? Ayman, can you unmute your?
Sure. Okay.
Yeah, thank you. Jazakallah khair.
The 3 studies was in heart failure, and we don't have the FAIR-HF and the confirm and the FIFT-HF also. But the new studies, which is coming, we're waiting for the results. It is assessing the long-term mortality in those trials, and they included patients who had ischemic heart disease with congestive heart failure. Some of studies also, they have included patients with the HFpEF, but isolated ischemic heart disease without heart failure, I didn't think we have this data.
Okay,
I don't know if you have another.
Thank you, Dr. Faiz. I have quite a nutritional question. Actually, two questions. The first question is that, up to your knowledge, is there a vegan processed meat that can substitute iron for individuals who are on vegan diet?
Well, to my knowledge, I mean, there isn't much, but some of the formulations which were marketed some time ago and they are present at this time, which is heme iron that is present in tablets. Definitely the heme iron is originally is an animal product. There is no heme iron in plants, but there are tablets that contain heme iron. They are not widely available, unfortunately, because their absorption is better. But since the recommendation is to go for IV iron, in those patients with really iron deficiency anemia, especially in association with heart failure, I think oral iron is pretty much a waste of time.
All right.
The iron, the meat contain ferrous, and ferrous is easily absorbed, easily through the duodenum. And the vegetables contain ferric, which is causing some damage to the duodenal cells because it's absorbed in the duodenum. That's why we don't have good absorption of iron, except if you add like citric acid or vitamin C or something like that. It is very difficult, and it is a trace element which has no excretion, no?
Yes, you
take it, it's not excreted.
Yes. Okay, from that point, maybe Dr. Fakhr can help us on that. So there's a lot of recommendation that iron tablets are not to be taken every day; they're to be taken every other day. And what's your input on this?
Yani, this is right. Lots of patients, we really suffer convincing them first to take it on empty stomach, which is a disaster. They will never agree on that. The other thing, if they are facing the GI problem, this is how we advise them to do. Either take it after food or even sometimes every other day. That's why we look for the sustained release tablet or capsule, where at least I'm sure that at least the elemental iron that is inside would be more than the 65 that I presented. But in the end, honestly speaking, they end up not taking it at all because they will forget it more. If you don't give it daily, most of the time, every other day means that they will not take it.
I guess
okay.
This
question.
Sorry. I guess this question stems from a study that has shown that there is no difference if you give it daily or every other day. And probably compliance is better, I mean, with a slightly better outcome. But at the end of the day, this is a trial and patients were on the trial, not the regular community patients.
Okay, thank you, Dr. Ayman, for cleaning that. A specific question about looking for the cause of iron deficiency anemia. Is it in your practice to look for a parasitic infection, like stool analysis or so?
Well, the most common cause of iron deficiency in the whole population is mostly non-healthy dietary habits. And in the young females, it's because of their menstruation, the pregnancy, and the lactation. And in the elderly, the #1 cause is GI blood loss. I mean, these are the most important factors that we see mostly in the population.
And pediatric, in pediatric, yes, it is one of the most important. But in elderly, usually they are taking non-steroidal anti-inflammatory drugs, and this can cause some sort of occult blood in the stool and GIT bleeding, and that's why they are exposed more to anemia of chronic illnesses, and started by normocytic normochromic anemia, then followed by to be converted to 2 types of anemia: iron deficiency or sideroblastic cedric anemia, decreased cedric acid.
Okay.
Sideroblastic anemia. Yes. Okay.
So staying with you, Dr. Faiz, if you have a patient in ICU or in decompensating heart failure, acute decompensating heart failure, who's admitted to the hospital, and you find out that he has an iron deficiency anemia, would you start immediately with iron replacement, or you would wait for his acute phase to pass?
Yeah, definitely we will concentrate on the management of acute heart failure management until patient reach to the stabilized or euvolemic status, especially if he's overloaded, because you know the CV will be low in that patients. And then at the end, before discharge and the final step, we just replace his IV iron by the ferric carboxymaltose. Yeah, it is not advised in acute setting, but before discharge in the same setting, same hospitalization.
Prof. Ayman, the question is related to iron replacement and renal failure. So is there any contraindication at a certain creatinine level where you would not replace the iron, where you will not use IV iron as a replacement, or is a creatinine level would guide you to a specific formula that you would choose over the other?
Well, in renal failure, iron deficiency is quite common, and most of the nephrologists actually give IV iron. They don't even use oral iron again, and there is no contraindication. It's to the contrary. These patients require more iron than others, and there is no contraindication to give IV iron. Now, recommending a certain IV iron formulation over the other is based on other factors not related to the renal failure itself. As we mentioned in the talks, it's the cost, it's the time, and many other factors.
So you mentioned, sorry, Dr. Faiz, you were saying something.
Yes, a definition of anemia in patient who had chronic renal failure is different from that of congestive heart failure. They consider that anemia is diagnosed when the ferritin level less than 200 and transferrin less than 25. It is different diagnostic. And usually they give erythropoietin, epipoietin or darbepoietin. And this is in cardio, we don't like it in cardiology case in heart failure cases because there was two trials, the stamina trial and the red HF trial. They gave it darbepoietin and they improved the symptoms in UHA class, global assessment, but at expense of increased thromboembolic complications and increased embolization, ischemic stroke. And that's why we usually didn't write it, but if the nephrologist come and he like to give it, he give it under his supervision and indication. And usually they didn't give correct anemia except if the hemoglobin less than 7. Usually this is what they do because they are lack of erythropoietin.
As mentioned by the guys here, just a small comment. I mean, patients with heart failure, I mean, they don't have a problem with erythropoietin production. But patients with renal failure, they have a deficiency in the erythropoietin production, and they need erythropoietin stimulating agents, he says. But the use of erythropoietin stimulating agents, aside from outside the presence of renal failure, is only recommended in patients who get chemotherapy and cancer. Otherwise, no.
Another
point, Dr. Kamal, we also have to consider, are they on dialysis or are they not on dialysis? This is the faisal between these two actually comments. Because again, if they're on dialysis, they have to be given erythrobiotin. But if they are not, so the iron is your choice, the injectable iron.
Okay, a dietary question. A participant says that I am on regular calcium supplement. Will this put me at risk for iron deficiency anemia due to malabsorption?
Dr. Fakhr.
Dr. Fakhr, is
most of our patients are on calcium and iron at the same time. No, it will not. Interaction in this case, this is what we call drug-drug interaction, where you have to separate the doses from each other. No, but taking calcium will not counteract with.
sorry, Dr. Khafakar, the question is not taking iron tablets and calcium tablets. It's just having calcium supplement for a
Okay.
long time. So will this interfere with the normal iron consumption in food?
Well, I think he means that the absorption of the iron would be affected by the calcium taken by the supplements. That's what I'm telling you. If he separates the dose, the calcium dose, from the dietary products that have the iron in, it will not affect. So the point here is the food-drug interaction in this case.
All right.
يعني مثل الشاي والقهوة يعني and tea you can everybody drinks tea. I mean, and that also well known to decrease the absorption of iron. But don't drink tea after food immediately if you have a problem in iron absorption or you have iron deficiency. But if you have iron normal subject and you don't have iron problems, then drinking tea postprandial is probably preferred to everybody.
Right.
Then will take us to another question. Why do you think that patients who are on iron supplements, once they stop their iron supplements, their ferritin level drops again?
It depends on what is the cause of iron deficiency to start with. I mean, if the cause is continuous, definitely when they stop the iron intake, the iron stores will be depleted again and they will develop iron deficiency. I mean, if the cause of the iron deficiency was temporary and this was treated, then they will just need the iron to replenish their iron stores and then they can stop iron. I mean, it's as simple as that. For example, somebody who has a gastric ulcer that is bleeding and causing iron deficiency anemia.
Yeah.
Once that ulcer is treated, and then he doesn't need iron anymore. I mean, he just eats normally.
Yeah. The iron, 20% of the iron content of the body are stored inside the cells, and 80% in the presence of heme or myoglobin or enzymes or whatever. And in patients who had chronic inflammatory disease or chronic inflammation, the release of stored iron is very difficult to go to the circulation again. That's why when they stop the IV iron, it goes down, because the hepcidin level, as mentioned by Dr. Ayman, is elevated, and this hepcidin is blocking the absorption and blocking the release from the reticuloendothelial system, the liver will spleen. It is some sort of, usually you notice this, they go down again to normal level because the stored iron cannot replenish.
So this is a question that focus on the blood pressure. So if your heart failure patient with iron deficiency anemia, if you correct the iron, will this improve the patient's blood pressure?
Blood pressure?
Yeah, that's the question. I'm just reading.
Yes, by indirect way, yes, a good question. I like these questions because by direct way, it will improve the ATP production. It will improve the muscle contractility. That's why the systolic blood pressure might go up, but you need long time to just wait for this because theoretically,
we don't have a direct answer for this.
No.
And there is
speculation.
I was waiting for this question actually. Is there a relation between iron deficiency anemia and COVID-19? Another question.
No, COVID-19 causes thromboembolism, increase thrombosis, and increase coagulation problem, and cause bleeding, and that's why may lead to damage, destruction of hemoglobin. تمام؟
بس هذه if you are talking about a patient who is on anticoagulant, يعني it interacts, their drugs that's given for COVID patients, it interacts with the oral or even the vitamin K anticoagulant, and this will lead to increase a level of these drugs in the blood. This are causing the bleeding in these patients. But direct answer for COVID, this goes back to Dr. Ayman and Dr. Faiz.
Yes. Now there is, I mean, I read recently something. I'm not sure about the whether this fact will materialize or is just an assumption. that COVID-19 displaces iron from heme. COVID-19 as a virus. And that causes the shortness of breath. And probably that's why patients do not improve on ventilators because of tissue hypoxemia. This is theory now. We don't know. It needs to be confirmed. But and that's why hydroxychloroquine, which stabilizes that, probably helps. So this needs to be confirmed. But in general now, in the presence of COVID-19 pandemic, we're trying to avoid patients from coming to the hospital and probably staying in the hospital for the time being. And that also, if we use an iron formulation that can be given within a shorter period of time and less visits to the hospital, that is more recommended now than ever, because you will decrease the exposure, the time of exposure of the patient to the hospital tremendously or significantly by using such formulation.
Yes, this is
okay. The flow of questions is not stopping, although our time has reached to the end. It's already 11:30. I do want to thank the Saudi Heart Association. I do want to thank I always keep forgetting it. Yeah, the Cardio Clinical Pharmacy Group, and I will definitely have to thank Dr. Faiz Al-Sha'ir, Prof. Ayman Hijazi, and Dr. Fakhr Al-Yubi for their participation. I'm having special thanks by your names, guys. Dr. Faiz, Dr. Fakhr, and Dr. Ayman on the chats, on the question and answers, and people are thanking you personally for your presentation. Thank you very much. Thank you again, Saudi Heart, and thank you again, Cardio Clinical Pharmacy. 10 طيبة مقبولة إن شاء الله. جزاكم الله خير جميعا، وكل عام وانتم بخير.
جزاكم الله خير. السلام عليكم. الف سلامة. السلام عليكم.